Welcome to the Deep Dive. Today we're zeroing in on pulmonary hypertension, PH for short. Basically, it's like high blood pressure, but, well, specifically in the lungs. And that puts a real strain on the heart.
It certainly does. It's a crucial area to understand, whether you're working in medicine or just interested in, complex conditions.
Absolutely.
Yeah.
So for this deep dive, we've gathered some comprehensive notes. Our mission, really, is to pull out all the key info on pH.
Exactly. A focused revision session, if you like.
Mm.
High yield, clear, and hopefully memorable. We want you to walk away feeling you've really nailed down pulmonary hypertension.
Okay, great. Let's dive straight in then. Pulmonary hypertension, the definition, what exactly is it?
Well, fundamentally, it's increased blood pressure within the pulmonary arteries. These are the vessels carrying blood from the right side of your heart to your lungs.
Okay.
And this usually happens because those vessels narrow down, making it harder for blood to get through.
Right, like a traffic jam.
Pretty much. And the big consequence of that increased pressure is the workload it puts on the right side of the heart. It has to pump much harder against that resistance.
Which can lead to problems down the line.
Yes. Over time, this can cause the right heart muscle to enlarge and, well, potentially fail. That's the serious outcome we worry about.
And I saw the term idiopathic PAH mentioned quite a bit. What's that about?
Ah, yes. Idiopathic pulmonary arterial hypertension, or IPAH. That's a specific rare form where, well, idiopathic means we just can't identify a definite cause even after thorough investigation.
So the trigger is unknown.
The initial trigger, yes, but we do understand the process. There seems to be some kind of initial injury to the lung blood vessels.
Right.
This sets off a cascade involving things like thrombosis, tiny blood clots forming scarring within the vessel walls, and then, as we said, the increased pressure and heart strain.
Okay, so even if we don't know the why, we know the what that's happening in the vessels.
Exactly. The pathway of damage is becoming clearer.
You mentioned PAH, pulmonary arterial hypertension. Is that different from PH generally? It sounds like there are different types.
That's a really important point, yes. PH isn't just one single disease. Classifying it is vital. It guides treatment, gives an idea about prognosis.
Okay.
So PAH is one major category, group 1 in the WHO classification. It includes that idiopathic form, IPAH.
Right.
It also includes heritable forms, often linked to mutations in a gene called BMPR2.
Ah, the genetic link.
Yes. And PAH can also be induced by certain drugs or toxins. Think back to those old appetite suppressants.
Fenfluramine.
That's the one, fenfluramine and dexfenfluramine. Plus, PAH can be associated with other conditions, HIV infection, portal hypertension, congenital heart disease, quite a few things.
So PAH is a specific subset focusing on the arteries.
Precisely. But there are other types of PAH too, beyond this PAH group.
Such as?
Well, there's pulmonary veno-occlusive disease that affects the small veins, not arteries. There's persistent pulmonary hypertension of the newborn, a specific condition in babies. And then, crucially, PH can develop because of problems elsewhere. Left heart disease is a big one, or general lung diseases and conditions causing low oxygen, like COPD.
Right, so secondary to other issues.
Exactly. And another key type is chronic thromboembolic PH CTEPH. That's where old blood clots in the pulmonary arteries don't dissolve properly and end up blocking flow.
That sounds quite different.
It is, and it has specific treatments. That's why the classification is so useful.
You mentioned the WHO classification. Can you just quickly run through those groups?
Sure. It's a system from the World Health Organization grouping PH into 5 main categories based on cause and mechanism. It really helps standardize things.
Makes sense.
Group 1 is largely that pulmonary arterial hypertension group we discussed, idiopathic, heritable, drug-induced, associated conditions.
Okay. Group 1 is PAH.
Group 2 is PH due to left heart disease, problems with the left side of the heart backing up pressure into the lungs.
Right.
Group 3 is PH due to lung diseases or hypoxia, low oxygen. Think COPD, interstitial lung disease. Group 4 is CTEPH, the one caused by chronic blood clots.
Okay.
And Group 5 is a bit of a catch-all. PH with unclear or multifactorial mechanisms, things like certain blood disorders or metabolic disorders.
That's a really helpful framework. So we've covered the what. Let's move on to the why, the etiology. What causes PH?
Well, as we said with IPH, sometimes we just don't find a specific cause. It's idiopathic.
Frustrating.
Very. But often PH develops because of something else going on, an underlying condition.
And what are the main culprits we should think about?
The notes list several key ones. Connective tissue diseases are definitely up there. Scleroderma, lupus, for example.
Okay.
Congenital heart defects, especially ones causing shunts or abnormal flow between heart chambers or vessels.
Right. Structural heart issues from birth.
Exactly. Then chronic lung diseases, COPD again, pulmonary fibrosis. They often lead to group 3 pH. HIV infection is a known association. Chronic thromboembolic disease leading to group 4 pH. And as mentioned, certain drugs and toxins.
So while IPH is maybe the classic form, pH often tags along with other conditions.
That's a good summary. IPH is a primary disease of the pulmonary arteries themselves, but pH overall. Very often it's secondary to these other heart, lung, or systemic issues.
You mentioned the familial link with IPH earlier, the BMPR2 gene. Can you elaborate a bit?
Sure. So in maybe 15% or so of IPH cases, it runs in families. The inheritance pattern is usually autosomal dominant, meaning you only need to inherit one copy of the faulty gene, often BMPR2, from one parent to have an increased risk.
But not everyone with the gene gets PH.
Precisely. That's the concept of reduced penetrance. Just having the gene mutation doesn't guarantee you'll develop the disease. Other factors, maybe other genes or environmental triggers, likely play a role.
That's really important. So who's most at risk then? What are the main risk factors?
Well, clearly a family history of PH, particularly IPAH, is a major one due to those genetic links.
Right, the genes.
And specific genetic mutations themselves, like in BMPR2. Exposure to certain toxins, fenfluramine and dexfenfluramine, are the classic examples from the notes.
Okay.
A history of congenital heart disease. Chronic lung diseases like COPD.
We keep coming back to COPD.
It's a big factor for group 3 pH, definitely.
Yeah.
Autoimmune diseases too, especially systemic sclerosis, which has a strong link to PAH.
Right.
And then other medical conditions like HIV infection or even schistosomiasis in certain parts of the world.
Okay, quite a list.
Yeah.
Now let's get into the real mechanics, the pathophysiology. What's actually going wrong inside those lung arteries?
This is where it gets quite complex at the cellular level. Essentially, the walls of the pulmonary arteries undergo significant structural changes.
Changes how?
Well, several things happen. The notes break it down nicely. First, there's vasoconstriction. The smooth muscle in the vessel walls tightens up, narrowing the artery.
Okay, they squeeze shut.
Then there's smooth muscle cell proliferation. These muscle cells actually multiply abnormally, making the vessel walls thicker.
Thicker walls too.
Wow. Yes. And third, endothelial dysfunction. The endothelium, the inner lining of the blood vessel, stops working properly. It normally helps keep vessels relaxed and prevents clots, but in PH, it malfunctions.
So the lining itself is contributing.
Absolutely. It contributes to inflammation and narrowing, and all these processes together lead to vascular remodeling.
Remodeling?
Yeah, it means the actual structure of the artery changes, often permanently. It's not just a temporary squeeze. The vessel architecture is altered in a way that obstructs blood flow long term.
So constriction, thickening walls, faulty lining, structural changes. What does all that do physiologically?
The immediate effect is a big increase in the resistance blood meets as it tries to flow through the lungs.
Higher resistance.
Which directly causes the pressure inside the pulmonary arteries to go up, elevated pressure.
Right, the hypertension part.
Exactly.
Yeah.
Now, the right ventricle of the heart has the job of pushing blood through those high-resistance lungs.
So it has to work harder.
Much, much harder. To compensate, the right ventricle muscle gets thicker and larger. That's right, ventricular hypertrophy.
Like any muscle being overworked.
Precisely. But eventually there's a limit. If the pressure stays high, the right ventricle can become overwhelmed, weaken, and start to fail. That's right, heart failure.
A really clear sequence of events, unfortunately. Now, someone comes in with shortness of breath, fatigue, symptoms that could be PH. What else could it be? What's the differential diagnosis?
That's crucial because PH symptoms are often nonspecific, especially early on. You need to consider a lot of possibilities.
Such as?
Well, cor pulmonale, that's right. Heart failure, specifically caused by lung disease, which can look very similar. Various cardiomyopathies, diseases of the heart muscle itself.
Okay.
Primary right ventricular failure, perhaps after a heart attack affecting the right side. Congestive cardiac failure from left heart problems is a big one. Causes similar symptoms.
Right, left heart failure backing up.
Yes. Also, recurrent pulmonary emboli, even small ones that weren't diagnosed. Problems with heart valves like mitral or tricuspid stenosis, narrowing, or tricuspid regurgitation, leaking.
Valve issues.
Pulmonary stenosis, narrowing of the pulmonary valve itself.
Mhm.
And beyond the heart and lungs directly, things like portal hypertension, severe obstructive sleep apnea, general chronic lung diseases, hypothyroidism, even sickle cell disease, and of course, an acute pulmonary embolism.
Wow, that's a huge list. Really emphasizes needing proper investigation.
Absolutely. You can't just assume it's pH based on symptoms alone.
Speaking of investigation, how common is pulmonary hypertension? What's the epidemiology look like?
The UK estimate is around 15 to 50 cases per million people, but that's a broad estimate.
Why so broad?
Because prevalence really varies depending on the underlying cause you're looking at and the population studied. And it affects all ages. It's not just an older person's condition.
And those specific types, IPAH and CTEPHs.
IPA is definitely rare incidence, is maybe 1 to 3.3 new cases per million people per year. CTEPH is slightly higher, perhaps 1.75 to 3.7 per million per year.
Still quite rare overall then, but it seems more common in people with existing heart or lung problems.
Oh, definitely. The notes highlight that it's found in a significant chunk, 18 to 50% of patients being assessed for lung transplant or lung volume reduction surgery. These are people with very severe lung disease already.
That's a high percentage in that group.
It is. And also in people with diastolic heart failure, the reported rates there vary wildly, from 7% up to over 80% in some studies, which is quite striking.
Wow, 80%. And the risk of CTEPH after a PE, a pulmonary embolism?
The estimates are somewhere between 0.5% and 4%. So most people who have a PE don't develop CTEPH, but a small percentage do. The risk seems higher if the clot was large, recurrent, or unprovoked, meaning it happened without an obvious trigger like surgery or immobility.
Okay, that makes sense. Let's shift to the patient experience. What are the typical clinical features? What symptoms should make you think of PH?
The classic symptom, the one that usually brings people in eventually, is progressive dyspnea. Shortness of breath, especially when exerting themselves, that gradually gets worse.
Okay, worsening breathlessness.
Yes. And fatigue. Not just tired, but really profound fatigue, often out of proportion to the activity level. Chest pain, often described as angina-like, especially during exercise.
Pain on exertion?
Syncope, which is fainting or near fainting, particularly during or just after activity. And just generally poor exercise intolerance, finding it harder and harder to do physical tasks.
And as things progress, signs of the heart struggling.
Exactly. Signs of right heart failure. That includes edema swelling, usually in the ankles and legs, a raised jugular venous pressure, JVP, you can see the neck veins are distended, and sometimes hepatomegaly and enlarged liver due to fluid backup.
Are there any other, maybe less common symptoms?
Yes, the notes mention a few others. Exertional dizziness, more severe fluid retention causing ascites fluid in the abdomen, sometimes tachyarrhythmias like atrial flutter, and rarely hemoptysis coughing up blood, which can happen in specific situations like Eisenmenger's or CTEPH.
Okay. And when a doctor examines someone, what signs might they find?
On examination, you might feel a right ventricular heave, a lifting sensation over the left side of the sternum. Listening with a stethoscope, you might hear a loud pulmonary second heart sound, P2.
Indicating high pressure.
Exactly. You might also hear murmurs, a pulmonary regurgitation murmur or a tricuspid regurgitation murmur, indicating leaky valves due to the pressure and right heart enlargement.
Right.
And then the signs of right heart failure, we mentioned the raised JVP, peripheral edema, maybe ascites.
But early on, it might be subtle.
Very subtle, or even absent. That's a major challenge for early diagnosis. And you'd also be looking for signs of any underlying associated conditions, of course.
Okay, so symptoms and signs are suggestive. What investigations are needed to confirm pH and figure out the cause?
It's a stepwise process. Usually starts with blood tests, routine biochemistry, liver function, thyroid function. Crucially, autoimmune screening for things like lupus or scleroderma.
Checking for those associated diseases.
Yes. A chest x-ray is usually done mainly to rule out other obvious lung problems, though it might show some suggestive signs like enlarged pulmonary arteries or right heart enlargement later on.
Not diagnostic itself.
Generally not. An ECG can show signs of right ventricular hypertrophy or strain, but again, can be normal early on. Pulmonary function tests are important to assess for underlying lung disease like COPD or fibrosis.
What about ruling out sleep apnea?
Good point. If suspected, polysomnography, a sleep study, is needed to check for obstructive sleep apnea, as that can contribute to PH. Sometimes, rarely, a lung biopsy might be needed, maybe to exclude interstitial lung disease.
Okay, those are sort of baseline tests. What about more specific cardiac and imaging tests?
Echocardiography, an ultrasound of the heart, is absolutely key. It's non-invasive and gives us a good look at the right ventricle's size and function. And importantly, it provides an estimate of the pulmonary artery pressure.
An estimate, not the exact pressure.
Correct. It's very useful for screening and monitoring, but not the final word on diagnosis. A high-resolution CT scan of the chest gives detailed lung images, helps rule out lung disease, and can sometimes show signs suggesting PH or CTEPH.
And for CTEPH specifically?
The best test is usually an isotope perfusion lung scan, often called a VQ scan. It's very sensitive for picking up the mismatched blood flow patterns caused by chronic clots.
Okay.
Cardiac MRI is also increasingly used. It has excellent detail on heart structure and function, particularly the right ventricle. It helps with prognosis and assessing treatment response, and in CTEPH, assessing operability.
But the definitive test?
The gold standard remains right heart catheterization. This is an invasive procedure where a catheter is guided into the pulmonary artery to directly measure the pressures.
It gives the precise numbers.
Exactly. It confirms the diagnosis, assesses the severity, and helps guide therapy choices, for example, by testing vasoreactivity.
Right. Essential for confirmation.
Yeah.
So once pH is confirmed, how do you manage it? What are the goals?
The main goals are, well, first, to relieve symptoms and improve the patient's quality of life. Second, to try and slow down the progression of the disease. And third, wherever possible, to treat the underlying cause if there is one.
And the approach depends on the type and severity.
Absolutely. Treatment is highly individualized. Managing the underlying condition, treating the scleroderma, the HIV, the sleep apnea is always step one, if applicable.
Makes sense. And the pH-specific treatments?
There are several classes of drugs. Vasodilators to help relax and widen the pulmonary arteries. Endothelin receptor antagonists, ERAs, block a substance that constricts blood vessels. Prostacyclin pathway agents are potent vasodilators. Some are given intravenously.
Right.
Phosphodiesterase 5 inhibitors, like sildenafil, also help relax the pulmonary arteries.
The same drugs used for other things sometimes.
Yes, same class, working on a similar mechanism in the pulmonary vessels. Oxygen therapy is used if oxygen levels are low, especially during exercise. Diuretics help manage fluid overload from right heart failure.
Any other approaches?
In rare, severe cases, an atrial septostomy might be considered palliatively. For Group 4, CTEPH, pulmonary thromboembolicectomy surgery to remove the clots can be curative for some.
That's a major surgery.
It is, but potentially life-changing for the right patients. And there are newer drugs constantly being investigated, things like guanylate cyclase stimulators and selective prostacyclin receptor agonists. For some specific PAH patients who respond well during catheterization, calcium channel blockers might be used.
So quite a few options, but complex decisions.
Definitely. And for patients with very advanced disease not responding to medical therapy, lung transplantation, or sometimes heart-lung transplantation is the final option.
A last resort. Given all this, what's the prognosis like for someone with PH?
It's highly variable. It really hinges on the underlying cause, the stage at diagnosis, and importantly, the response to treatment. Early diagnosis and treatment are crucial for improving outcomes.
But it's generally progressive.
Unfortunately, yes. For many types, it is a chronic and progressive condition. Untreated, it often leads to worsening right heart failure and, well, reduced life expectancy.
Are there specific survival figures? They often help put it in perspective.
The notes give some sobering figures, mainly reflecting historical data before modern therapies were widespread. For severe PH, say, mean PAH over 55 mmHg with right heart failure means survival without treatment was estimated around a year.
Only a year?
Yes. If the pressure was lower, under 55, and the right ventricle was coping better, maybe closer to 3 years on average. For untreated idiopathic PAH specifically, median survival was often quoted as 2 to 3 years.
Those numbers really underscore the seriousness.
They do. Thankfully, outcomes have improved significantly with targeted therapies, but it remains a very serious condition.
And what are the main complications people might face as the disease progresses?
Well, the big one is progressive right heart failure. That's the main consequence of the high pressure. Arrhythmias, irregular heart rhythms, are common and can be dangerous.
Okay.
There's an increased risk of thromboembolism, blood clots forming, particularly in the pulmonary arteries themselves. Patients can be more susceptible to respiratory infections.
Makes sense. The lungs are already stressed.
Exactly. And then there are complications related to the underlying cause, if there is one. Plus, pH significantly increases the risks associated with surgery and pregnancy. Pregnancy, in particular, is very high risk.
Really?
Yes. Tragically, sudden death during or shortly after childbirth can occur in women with severe pH. Other issues include worsening peripheral edema, fluid backing up into the liver causing hepatic congestion, and potentially cardiac cirrhosis over time. Pleural effusions, fluid around the lungs, worsening exertional dyspnea and syncope, and ultimately the risk of sudden cardiac death.
That's a very comprehensive and, frankly, quite daunting list of potential problems. It really shows the systemic impact.
Right, well, we have covered a huge amount of ground there. From the basic definition of pulmonary hypertension, through its causes, the risk factors, the nitty-gritty pathophysiology,
How it affects the body.
the differential diagnoses, epidemiology, the clinical picture symptoms and signs,
How we investigate it, the management options.
prognosis, and those potential complications. It's clearly a very complex condition.
It really is. So
Yeah.
many facets to consider.
And understanding all those different aspects is key.
Absolutely. And maybe a final thought to leave people with. Given this diversity, the different underlying causes, the varying prognosis, the different ways it progresses,
Yeah.
what do you think are the biggest challenges right now in trying to develop treatments that could be universally effective across the different types of pulmonary hypertension?
That's a great question. Tackling that heterogeneity must be incredibly difficult, something definitely to mull over.
Well, if you want to solidify your understanding of pH or revise other key medical topics, definitely check out the resources online.
Yes, PassTheMSRA.com and FreeMSRA.com have got loads of great material.
Fantastic. Thank you for joining us for this deep dive into pulmonary hypertension.